Welcome to episode 34 of the ProPA podcast. I'm your host, Professor G, and today we're rounding out our Restrictive Pulmonary Disease series with a high-yield episode on sarcoidosis. Sarcoidosis is a fascinating systemic disease that can affect nearly every organ, but its primary involvement is in the lungs. In this episode, we'll break down the basics of sarcoidosis, focusing on pathophys, clinical presentation, diagnosis, and management strategies. And by the end, you'll be ready to tackle this topic on the PANCE and in clinical practice. Let's get started. First, let's look at the kinderpatho. What is sarcoidosis? Well, sarcoidosis is a systemic granulomatous disease of unknown cause that most commonly affects the lungs and intrathoracic lymph nodes. It causes non-caseating granulomas, which is basically a collection of immune cells, and this is the hallmark of this disease. Now, sarcoidosis is caused by an exaggerated immune response to an unknown antigen. And when this happens, T helper cells release cytokines, leading to recruitment of macrophages and lymphocytes and formation of these non-caseating granulomas in affected organs. These granulomas can lead to fibrosis and loss of organ function over time. All right, now that we got that patho down, let's look at the risk factors. So, age, the most common is in adults aged 20 to 40 years old, so young. Gender is going to be more in women and individuals of African American descent. Geography, we see a higher prevalence of this in the Northern Hemisphere, and there is an increased risk in first degree relatives, so there is some correlation with family history. Now, how do these patients typically present? Well, pulmonary symptoms. 90% of cases are going to present with pulmonary symptoms, including dry cough, progressive dyspnea, and chest pain, which is sometimes pleuritic. We can also see an array of extrapulmonary manifestations. Lymphadenopathy, we're going to see hilar and mediastinal lymph node enlargement. On the skin, we can get erythema nodosum, which are these painful red nodules typically found on the shins or extensor surfaces. We can also see a pathognomonic type of skin lesion called lupus pernio, which is this chronic violaceous or purple plaque on the nose, cheeks, and ear area. We can also see problems with the eyes, like uveitis, which can cause blurry vision, photophobia, and pain. We can see problems with the heart, like arrhythmias, heart blocks, or cardiomyopathies. It also can affect the nervous system, so we can see facial nerve palsy, seizures, or meningitis-like symptoms. And last but not least, it can affect the liver and the spleen, causing hepatosplenomegaly. In addition to all of these extrapulmonary manifestations, we also tend to see these systemic symptoms of fatigue, fever, and weight loss. All right, so how do we diagnose sarcoidosis if it's so difficult, has so many different manifestations, right? So, chest x ray, the classic staging system on a chest x ray is stage 1, we'll see bilateral hilar lymphadenopathy. Stage 2, we'll see bilateral hilar lymphadenopathy with parenchymal involvement. In stage 3, we'll see parenchymal involvement only. And in stage 4, we'll see full blown pulmonary fibrosis. Now, on a high resolution CT, we will identify these nodular infiltrates and mediastinal lymphadenopathy in more detail. Once we see these findings on imaging, we'll want to do a tissue biopsy, and this is going to confirm the presence of those non-caseating granulomas. The confirmation or common biopsy sites are going to be skin lesions, lymph nodes, or lung tissue via bronchoscopy. Now, laboratory findings. You will often see an elevated serum angiotensin converting enzyme or ACE level. So look for that in your vignette, although it is not specific, but it is supportive of the diagnosis of sarcoidosis. We also tend to see hypercalcemia and hypercalciuria due to granuloma production of calcitriol. So you see extra calcium floating around. Pulmonary function testing typically shows a restrictive pattern, which includes, again, reduced FVC and TLC with a decreased DLCO. All right, let's look at the management. So symptomatic or mild disease, often we just observe, and in many cases, it resolves spontaneously. However, the first line treatment is going to be systemic corticosteroids. So prednisone is the cornerstone of treatment, and it's indicated for moderate to severe disease or if you have organ involvement like lungs, eyes, heart, or CNS involvement. There are also some steroid sparing agents we can use when long term corticosteroids are needed or are not tolerated. And examples include methotrexate, azathioprine, and hydroxychloroquine. And this hydroxychloroquine is specifically useful for skin lesions. We can also refer the patient for pulmonary rehabilitation, which improves exercise capacity and quality of life in patients with advanced disease. And we also need to manage the complications. So, heart failure, arrhythmias, or advanced pulmonary fibrosis may require some specialized treatments. Like we mentioned before, there are quite a few complications that can arise with sarcoidosis. Number one, pulmonary fibrosis. So, this can lead to chronic respiratory failure over time. The hypercalcemia can cause kidney stones or nephrocalcinosis. The cardiac sarcoidosis can cause life threatening arrhythmias or sudden cardiac death. And the neurosarcoidosis may present as cranial nerve palsy, seizures, or even meningitis. All right, so if you're reading a vignette and you're not sure if it is sarcoidosis or not, here are a few buzzwords to help you hone in on this diagnosis. Number one, non-caseating granulomas. Number two, bilateral hilar lymphadenopathy. If you see this in conjunction with erythema nodosum or lupus pernio or an elevated serum ACE level, or you have a young adult female African American with pulmonary symptoms, think sarcoidosis. Now, not everything that is a buzzword or that is textbook is always sarcoidosis, but in vignette world, in the book med, textbooks tend to emphasize granulomatous ACE levels, chest X-ray staging, and corticosteroids as first-line treatment. On the street, there are many mild cases that resolve on their own, so steroids can be avoided in asymptomatic patients. And hypercalcemia can be overlooked complication, especially in the outpatient setting. So it is a little more complicated, I think, in the street than it is in the book bed. But just be vigilant. Just be looking out for it. Keep it on the back of your mind on your differential, and you won't miss it. All right, quick clinical pearls. Sarcoidosis is a diagnosis of exclusion, so rule out infections like TB or malignancy. Also, chest X-ray staging is key to diagnosis and monitoring disease progression. Elevated serum ACE levels are supportive but not specific to sarcoidosis. Patients with erythema nodosum typically have a good prognosis, whereas patients with lupus pernio typically have a worse prognosis. And always monitor for hypercalcemia. All right, that was a quick run through sarcoidosis. Now let's test our knowledge. So we have a 31-year-old African American female who presents with a dry cough, fatigue, and tender nodules on her shins. Chest X-ray reveals bilateral hilar lymphadenopathy. What is the most likely diagnosis? Is it A, tuberculosis, B, sarcoidosis, C, idiopathic pulmonary fibrosis, or D, silicosis? If you said B, sarcoidosis, you've been paying attention. Good job. This patient's presentation of erythema nodosum and the bilateral hilar lymphadenopathy on chest X-ray is classic for sarcoidosis. Question 2. We have a 50-year-old male with sarcoidosis who presents with blurry vision and photophobia. He is diagnosed with uveitis. What is the most appropriate treatment? Is it A, topical corticosteroids, B, systemic corticosteroids, C, hydroxychloroquine, or D, observation only? I'll give you a few seconds. This one's kind of tough. If you said A, topical corticosteroids, you are right. So we didn't really talk about this, but for isolated uveitis, topical corticosteroids are the first line treatment. Systemic corticosteroids may be required if other organs are involved. All right, well, I want to thank you for joining me on this episode of the Pro PA podcast. I hope this helped clarify this complex systemic disease and gave you the tools to diagnose and manage it effectively. This episode concludes our Restrictive Pulmonary Diseases series. If you want to take a deeper dive into these conditions, be sure to check out my pulmonary medicine playlist on my YouTube channel, Professor G PAC. And if you found this episode helpful, hit follow and turn on notifications so you never miss an update. As always, this is the Pro PA Podcast, where future pros in medicine are made. I'll catch you in the next episode.